that's it. We can.
Good, that's great. That's what my office looks like. One day I might go back to it. It was last March. So that's University of Leicester. So I'm a professor in environmental epidemiology at the University of Leicester. And as of last year, we also have a health protection research unit in environmental exposures and health. And within that, we have a focus on the built environment, and one of our project themes is around bioaerosols, and that is led by Emma Margillo at Public Health England. What I'm actually going to talk about today is an interpretation of this quite broad topic I've been asked to speak on, which is challenges and opportunities for bringing together exposure and health data to identify potential health impacts of bioaerosols. So I thought the best way to start to illustrate some of the issues was to talk through about 6 years of work that I originally started at my previous post in Imperial College London. And I'd like to particularly credit Philippa Douglas, who's in the middle in the high-vis suit and the hard hat, doing some measurements at a composting site. And she drove a lot of this work and did a PhD estimating emissions of bioaerosols from composting facilities. So the question that we had were, are there health risks from living near large composting facilities? So it's a fairly straightforward, policy relevant question, actually quite difficult to answer. As I think most of you will know, composting is increasing in the UK, and there's been a big drive where we've run out of landfill site space in Europe, and we're trying to divert waste from landfill. So there are lots of composting sites, large-scale composting sites that are opening up, and it's resulting in some elevated concentrations of bioaerosols. So I don't think with this group I need to explain what bioaerosols are, but there's certainly a lot of uncertainties about both exposure and dose response. And the research is needed to try and help with policy and regulating these sites. And one of the first things that we did, as everyone would do, would be to see what's already been done. So we did some systematic reviews. So the systematic review on the left-hand side was published in 2016, and that identified 48 studies that just looked at exposure, 9 that looked at health, and 9 that had both exposure measurements and health. Most of the health-related studies were occupational. They were short-term, and most of them showed some relationship with respiratory symptoms and small decrements in lung function. There were a very small number of community studies, and they tended to rely on self-report of health complaints, which may be prone to some bias in the participants who actually responded to the surveys. So there was an update in 2019, identified another 23 studies. Again, there were more exposure studies, 15 exposure studies for health and 4 studies with health and exposure, but the conclusions really were very similar. Most of the studies available are related to occupation. So that's useful because they can tell you about what type of health effects to look for, but they may not be applicable to a general population because people who work tend to be healthier to be able to go out to work. So what we did first off was what sounds like a quite simple question. We had in the unit, we had all of the hospital admission data for England that we had by postcode. So we knew where people lived and were being admitted to hospital from. And we also got the data on all of the permitted large composting sites and tried to relate those together. And what sounds quite simple, actually in practice has quite a lot of steps and decisions and choices. So on the right-hand side of this slide, I've got some of the decisions and classifications that we had to go through. So we were, for example, only including the large-scale sites that were large enough to need a permit. So we missed a lot of smaller scale sites. Sites have, some of them are totally indoors, some of them are indoor with an outdoor component, and some of them are totally outdoors. There was also issues about sites opening times, so we had to take account of that. So we looked at 2008 to 10 in this specific study, and then a later study looked at later years as well. So then the next thing we had to do was Pippa took all the sites and put them into Google Earth, identified the sites, and of course they're not points, they're area sources, and we didn't have information on where the active sites were within that, where the windrows were being turned and giving off bioaerosols. And of course those are changing over time, so that's a sort of complication. You've got an area-based source, but you're not sure exactly where the emissions are coming in that. So you can assign distance bands around that. We had to make some executive decisions on what were appropriate bands, and then we had to relate them to the population data. So although we know the postcodes of the emissions, to get a rate we needed the population, and the population is in small area units. So this is a census, a smaller census unit that we had, and the geography is different from looking at the bands. So this, on the right hand side here, we've got some sites with bands round, and then with this sort of squiggly black lines are the population. So these are units of about 400 people. So you can see that there was a bit of a mismatch, and we had to work out how to assign the geography based on a sort of population weighting of that. So there's already quite a lot of potential for misclassification errors in this in terms of exposure. So we went on to look at the distance bands in relay and the hospital admission rates. We didn't have enough people living within 250 metres of a site to be able to look at the rates. And in this, we've got the bands are here on this side, the three different bands. And then we also looked at distance or log transform distance as continuous. And we made some adjustments for the deprivation level of areas, because that can affect your hospital admissions, and we also looked at a proxy for smoking. And we ended up with what I would call equivocal results. So there was possibly a small increase in risk. It was very much on the borderline of statistical significance. We certainly didn't find any strong effects from living near sites, but we were at the stage that this could just be some of the errors that we've introduced in the study, but it's something that we'd like to go and look at in more detail. So our next step was to try and improve our estimates of the exposure. So this built very heavily on the PhD on looking at modelling Aspergillus fumigatus exposure from composting facilities from Pippa Douglas, and then we worked with Enda Hayes and Ben Williams in the University of the West of England to do more detailed modelling of that and to apply it to the sites that were open between 2005 to 14. And we hoped very much we'd be able to get daily estimates of emissions, but we found there were too many uncertainties in the modelling process to characterise those in terms of a quantitative number, and that affects our analyses that we can do on a health basis. So we couldn't look at, so you know, on days when levels are very high, do you see higher hospital admissions that day or the following day? So we didn't have enough precision on our estimates to do that. So we ended up looking at longer term averages and dividing them into quintiles. And we found in this modelling exercise that you know, the emission sources and pollution deposition was quite important, and of course wind speed and meteorological factors are also important. So our next study was to use these improved modelling estimates and look at composting facilities between 2005 to 14. And that big paper there was published in Environmental Research last year. So we had 76 sites we were able to include. We had 250,000 hospital admissions within 4 kilometres of that site. We did some quite detailed statistical modelling here. So we allowed for some differences, some clustering within our data, and we allowed for differences between composting facilities. So for example, we found that the highest levels for some composting facilities were actually the lowest band of level of exposure in other facilities, and that is, you know, largely driven by how you know, the tonnage that's going through them. And just on the bottom here, I've got the difference between looking at the exposure circles, which we did in the previous paper, and then these coloured dots are the exposure quintiles. So red is the highest exposure. So instead of circles, they're sort of wedges, which is obviously showing a big wind difference. So we're trying to get rid of that misclassification that was related to just using circles. But in fact, we didn't find any associations with any respiratory condition, and we also looked at them specifically for asthma, COPD respiratory infections, and for cystic fibrosis, who might be a particularly susceptible group. So I've got a few slides here now just on some thoughts about future work. So I think the design of your study, this might seem obvious, but it's something that's worth coming back to, is what's your research question? Because that really drives how you're going to look at the exposure and the outcomes. So as a result of the work that we've done looking at general population, that's now being carried forward at Imperial, looking at sensitive groups, and they're using the cystic fibrosis register and looking at people with cystic fibrosis who live near registered composting sites, and the registry has quite detailed information on exacerbations, for example. Other sensitive groups could be asthmatics who are known to be sensitized to particular pollens or fungi. Occupational studies can be very helpful, and there's sort of a captive population quite often, and they have higher exposures, and it can be quite useful to look at particular mechanisms and maybe also to collect biological samples. There are a lot of health data sets that are available that may or may not be suitable, but there's certainly, so I think that should be 2.6 million, as a typo there. Over 3% of the UK population are currently in a cohort study, which is quite astounding, really. So there are very good, extensively phenotyped collections of people with health history that are known at different parts of the country, and some of them are national. For some studies, you may be better off with a biomarker and then using the biomarkers to make inferences about the population. And then I've got at the bottom here about improving exposure estimates, because I've got some more slides on this. So it is crucially important. So I've got a little matrix here. I won't go through it in detail. Thinking about PM 2.5, that's probably one of the easiest pollutants to get information on. Pollens are much harder to get information on. You know, we have some ambient daily monitoring data, but it's a relatively small network that probably has a limited range in which it's completely valid. We have some sort of more national, what I call modelled ambient core scale data, but I'd be hesitant to use those in a health study. And then we have very little information on what's getting indoors. And then for fungi, there's almost no data, and we have one station that's currently monitoring on a daily basis, and that's operated by Kat Pashley at Leicester. So, and I think there's a couple of slides I've just borrowed from Kat, just to try and point out that we don't, in the monitoring that we do, we still don't monitor everything. So there are a lot of pollens that we don't actually monitor that are on this slide here. So we're monitoring 12 of the regularly of the pollens that might be important. And then it gets even more complicated when we think about fungi, and there's a very limited number that we collect information on, and also we've got issues about the seasonality, and there are different criteria about how you might define the seasonality. So I think there's a lot of exposure work that would be quite helpful to feed into some of the future health studies. So this is my last slide, and I've got a cheeky advert on the right hand side. We're organising a Occupational and Environmental Epidemiology Society meeting at Leicester in June. I'm very happy to welcome abstracts on relevant research, including on bioaerosols for that. Thank you.